to Disrupting Death. Keri-Lyn, I'm, as per usual, excited about our guest this month. Dr. Eric Mathison has been recommended to us by a number of sources as somebody we just have to have a conversation with. Eric is an assistant professor of philosophy at U of T in Scarborough, where he researches bioethics, including ethical questions about medical assistance in dying. And I have to admit, a little bit nervous to talk to a bioethicist, to get a little bit into the weeds about what MAiD looks like from an ethical or rights perspective. And Eric has been a clinical ethicist for Alberta Health Services, which involves working with healthcare providers to address the ethical questions that come across healthcare providers every day as they care for people. He's also done some policy work related to the pandemic, including the ethics of mandatory vaccine policies and the distribution of scarce resources fairly. And I know, Keri-Lyn, you and I have both checked out his work and are excited and ready, so let's get the conversation going. Welcome to Disrupting Death, Eric. At the World Federation of Right to Die Societies conference in Ireland last year, we heard that you said you're in the argument business. What does that mean? And can you please share a little bit about what you're up to these days and how you became involved with assisted dying discussions, thinking particularly about end-of-life rights and autonomy?
Sure. Thank you very much for having me. So I'm an assistant professor in the philosophy department at the University of Toronto Scarborough, and philosophers are in the argument business. So this is something that I've been doing for a while now. I work in bioethics, so ethics issues that arise in healthcare, and I was previously a practicing clinical ethicist. But I first found out about assisted dying. There was actually a talk when I was doing, I think in the early, like the first year of my PhD, and it was Wayne Sumner, who's a philosopher, Jocelyn Downey, who's a law professor, and James Downer, who's a palliative care physician. And I knew Wayne Sumner, but I had never heard of Jocelyn or James. And this was before Carter. This was 2013 or something. But little did I know, I mean, these three are like the all-star cast of assisted dying arguments and the legal cases and so on. So I saw them give a talk, and I came out of that presentation where they all went over ethical arguments and legal arguments. And I just thought, oh man, this is solved. It's worked out. It's so rare in philosophy to find something that you just go, oh, okay, like I'm happy with these answers. Of course, there's like more stuff to figure out at the margins, but I left that thinking, I'm totally convinced about this. It wasn't something I had spent a whole lot of time thinking about before. And so since then, I've been interested in it and have gotten more involved in writing about it and talking about it.
That's fabulous. And I love the idea that there continues to be space and roles, and I would add responsibilities for us to have arguments. I'm saying that in air quotes, which you can't catch on an audio podcast, of course, about assisted dying. Because as you alluded to in the margins piece, I think we have some important conversations that need to happen in those margins. And I appreciate you talking a little bit about making the connections with Dr. Downey and Dr. Downer. And you talk about bioethics, and I have the opportunity to be on the MAiD Death Review Committee for Ontario and get to share that space with a few different biomedical ethicists and law professors. And the discussions, I think, are important when we talk about extending the conversation around the margins. And so I'm interested, can you speak to sort of where that extends in your work as a professor at U of T and your theoretical and your practical experience and what that looks like in your work?
I'm interested in finding questions where there's a close connection between a practical situation that clinicians are facing or that is occurring in healthcare right now, but that quickly, if you pull on the thread, it opens up to a very deep issue. And there are certain ones that, although people are aware of the topics, that they actually haven't really had a lot of attention in either academic bioethics or practically. One that I am working on a lot right now is issues around consent, especially around coercion. So this came up during the pandemic, that there were people who were worried that mandatory vaccination programs, for instance, were coercive. And coercive in a sense that it would invalidate informed consent. It would mean that the person was pressured and so wasn't actually making a free choice. And this was something that I thought about at the time and was doing practical work as a clinical ethicist. But as I tried to look into the research on it, there wasn't a whole lot written about how do we actually parse those sorts of arguments. And assisted dying is another one, that there are big picture questions about what the goals of medicine are. How do we balance giving people autonomy while also protecting vulnerable people? How do we think about the access in a public healthcare system? There are practical issues that connect to deeper philosophical questions.
Thank you for that. And when we talk about coercion, when I think about as it relates to medical assistance in dying, we often hear that it's concerned about healthcare providers and how they introduce MAiD to an individual. But the interesting piece I was thinking about was around caregiver burden and thinking about how we have some gaps in our system that don't necessarily support caregivers to the way that they could be or should be. And thinking about that as a piece of perhaps unidentified or unspoken about coercion. Is that something that you're encountering at all?
I think that really at its core, the question is trying to figure out when is it just families being families, that we can influence each other. I have a 5-year-old daughter and she hasn't actually done this yet, but I could imagine her saying, I want a puppy, and like every day asking me for a puppy. And then eventually, if I relent and say, okay, fine, we'll get a puppy. Sure, she's pressured me, but it still seems like I've made kind of a free choice about that. In more kind of serious clinical situations, if a family member says, well, I think you should do this, pressuring the patient, then it is difficult to figure out, or this is the question I'm interested in, is like, when does that tip over into something that is now ethically fraught? And then what do we do about it? And so I think that patients being worried that they're going to be a burden is something that, that comes up with MAiD. And also how family members, their role in caring for their loved one and how that relationship changes over time. Those are extremely complex and I think like are ripe for philosophical analysis to figure out how do we address those in a way that's like good for everybody.
Thanks for that, Eric. I want to pick up on something that you just talked about. When is it just families being families? Because some of our research involves caregivers, families, friends of people who have opted for MAiD. And they express a lot of confusion, a lot of misunderstandings, or perhaps even disinformation that they receive about MAiD as a procedure, as a process, as an experience. And this inevitably in our experience, and I think Kathy might back me up on this, really has to do with track two MAiD. It has to do with this sort of newer track that people can now follow the trajectory of. Your Substack and podcast, Value Judgments, you broach a wide range of issues associated with autonomy. And going back to this issue of track two, again, could you talk about Bill C7 and Track 2, what it means, and perhaps provide some context about why there is a plethora of misunderstanding, information, and even disinformation?
Sure. So the quick backstory is that Carter, the Supreme Court of Canada decision, it was decided in 2015. It was a unanimous decision. And the justices in that decision gave a framework for what assisted dying, like a legal kind of pathway. And that included having what they call a grievous and irremediable medical condition. You had to be 18 or older. You had to have decision-making capacity. And nowhere in their decision did they say anything about the timeline to natural death. So they published their decision, and then Parliament had a chance to enact a law, and so they wrote Bill C14, and which was basically copy and paste from Carter, except that they added that the person's natural death had to be, quote, reasonably foreseeable. So that became law, and that was the law for a little while, but it very quickly became clear that there were problems with this. It was, from a legal perspective, it was vague. And so that meant that people were unsure about what it meant. Did that mean 6 months? Did that mean 10 years? As a philosopher, I teach a course called Death and Dying. And I joke that, all of our deaths are reasonably foreseeable. Like we don't know when they're going to happen, but we can see them on the horizon. And so there were a lot of issues with that. But the law changed because two people, Jean Chouchon and Nicole Gladue in Quebec, they were both people who had long-term disabilities they had their entire lives. And they argued that they had a grievous and irremediable medical condition that was causing intolerable suffering. But the nature of their condition was such that they were not likely to die from their medical conditions in any foreseeable amount of time. So they argued that C14, and specifically the reasonably foreseeable death condition, was unconstitutional. A Quebec Superior Court judge agreed, and then the federal government decided not to challenge it. So that's why they passed C7. So that's all kind of by way of legislative history. But what that did was it expanded access to assisted dying, making it more in line with what it seems like what the justices in the Carter decision had in mind. So now, as you alluded to, there are two tracks. So the majority of people, 96% of people in 2023, were track one. And so that meant that their death was reasonably foreseeable. They have conditions like cancer and so on that they'll die in the near term. And then there's a small percentage of people, around 4%, whose deaths are not reasonably foreseeable. So the main conditions that they have are neurological conditions or other things, frailty, diabetes, things where the disease course is less clear. And these are the ones that tend to make the news the most because they tend to be complex. It's younger people sometimes. And the amount of comorbidities, that multiple conditions that people have, that it's something that people who are opposed to MAiD have focused on as being a source of opposition. Now, why is there so much disinformation? I think sometimes it is just like we genuinely have disagreements about the ethics of it. But I think that the way that these cases are portrayed in the news are often very limited, that it's the lack of the full access to the information. And then I think in other cases that the statistics that are out there, that people are just misinterpreting them, deriving conclusions from them that I think are unsubstantiated. And why is that? I think it suits their conclusions, maybe other reasons. So there's a whole kind of different range of ways that it comes up, but those are some of the main ones.
Thank you for that. And one of our goals with this podcast is to have the conversations that will hopefully provide an alternative to some of the disinformation. And I would say some of that is caused because of sound bites and looking for appealing headlines, so to speak, within the news. And that's part of our goal with having conversations about medical assistance in dying, that we can unpack a little bit more about that. And Eric, when I was looking into the work and the things that you've contributed in the MAiD space, one of the things that really caught my interest is that you are a proponent for non-medical form of assisted dying. And I wonder if you can tell us a little bit more about what a non-medical form of assisted dying looks like.
Sure. So I think there are two main ways, non-medical or demedicalized. One of the ways is the kind of framework of approval or the number of criteria that a patient has to meet in order to qualify for an assisted death. And I think that currently, even with track 2, with that expansion, I think it's too strict. It means that people who have full capacity to understand what they're doing, they've made a decision, an informed and stable decision about the quality of their life, no longer making their life worth living for them, and they're prevented from doing this. I think that no matter what, kind of having medical criteria like that, besides decision-making capacity, I think is going to be overly restrictive. So part of it is just from an autonomy point of view, I think that people should be allowed to be authors of their own lives, to make decisions for themselves if they have the capacity to do so. And having doctors say, or having the government say, we don't think you're actually able or qualified to make this decision, you need our approval, I think that's ethically unjustified. The kind of other part to it is that the relationship with physicians and the broader medical system and MAiD has improved a lot in the decades since Carter. There are still access restrictions. Many healthcare providers don't want to be involved in MAiD. There are some providers out there who are doing amazing work and are extremely involved in and advocating for it. But I think that just a demedicalized approach would mean that there would still be a role for healthcare providers, but it would be less demanding for them. They've got other stuff going on and other important work to do. So those are the two things. It's kind of an autonomy-focused argument. And I think just from a structural point of view, that if we can move those, like that pathway to a different kind of direction without requiring involvement from healthcare providers as much, then those would both be positive.
I agree in terms of this idea of demedicalizing MAiD. I have strong concerns that I've talked about here on the podcast around when we consider MAiD to be a medical procedure as opposed to a massive, essential, important, and meaningful life event that I think should be how we are seeing the end of our lives. And I remember having worked in palliative care from way before MAiD was legalized and what was going on in Oregon, and having the thought of, does applying to die, which was the process at the time in Oregon, is that an autonomous, is that a dignified approach? And now I hear here in Canada of people needing to book the time with their physician to be able to access MAiD because of some of the challenges within our healthcare system. And I too teach a course or two on end of life. And I often say to students, we need to remember that medical assistance in dying is not a colonoscopy. These are very different aspects of the healthcare system. And so this idea of demedicalization is a really important one. And we've been privileged to hear stories of perhaps some of the really good MAiD care providers that you're talking about, Eric, and who are providing MAiD based on the individual schedule in the setting that they want. And sometimes very eclectic settings, or settings I would like for myself outside in the forest, which to me does that demedicalization. So I'm wondering, what else do you think is required for us to shift away from the procedural piece of MAiD to more of the natural part of dying?
Yeah, I think it would be figuring out like what is the actual kind of workflow or process that the person has to go through. The default, the law is already clear, and this applies in medical decision making as well, that an adult is presumed to have capacity unless there's a reason to believe that's not the case. And so I think we could have a somewhat kind of thicker, more stringent idea that there's maybe just a capacity review that the person has to do. But I'm actually in favor of an even more moderate kind of approach where somebody could intervene if there was a reason to doubt, and there would be like a minimal assessment. Figuring out the kind of capacity piece is the key part to it. And after that, there would be, I think, two tracks. So the jurisdiction that's closest to what I have in mind is Switzerland, where it ends up being healthcare providers who do it because of the pharmaceutical access. But anyone can assist somebody in an assisted death so long as the person doing the assisting doesn't have a selfish motive. That's how the law defines it. The percentage of people in Canada right now, it's like almost all, like 99.99% of people have euthanasia, where the clinician directly administers the substance. You can move it so that you can get a prescription you can take home with you, like in Oregon and the other US states. So that could be part of it, where it gives people more choice. But there are still going to be people for whom they need a healthcare provider to administer. So this is why I'm not exactly sure what the right kind of term is. I want to demedicalize it, but I think healthcare providers there'll still be a role for them to play in some of these cases.
Eric, I think that's quite an interesting idea, that there would be perhaps a team that was made up of, as you suggest, medical professionals, but also non-medical professionals. Let's go back to the capacity piece. What would a non-medical or demedicalized assisted dying experience, event, what would that look like in terms of access for people who are living with dementia in Canada? What might it look like for mature minors? And I know that's a subject as well that you've touched on recently in your work. Perhaps you could speak about those aspects of the idea.
Yeah, so there are going to be more complex or harder cases. I think that in something like dementia, that in the early stages, the person could still have full capacity. But as we see right now in everywhere but Quebec, that there's a time limit, because by the point where they would usually qualify, they've lost capacity and can no longer give consent. Quebec has addressed this by having advance requests, which started last fall, and we're watching that closely. I think that's a very promising experiment. We'll see how that goes. So we can imagine an advance request sort of process where you make an agreement with a healthcare provider or somebody else. You're diagnosed with dementia. Once the dementia gets to a certain point where you meet criteria that you and the person you're making the agreement with have agreed to, then they could proceed with the assisted death. In mental illness cases, they're ones that the public really worries about and get a lot of attention. And C7, that allowed track 2, it explicitly forbids somebody to qualify based only on a mental illness. And I think that's unjustified, because I think that although a mental illness in some cases can affect decision-making capacity, that need not be the case. That we do capacity assessments. There's lots of literature, studies where people including inpatient psych units are given capacity assessments, and many of them have full capacity. So it's a mistake, or it's a misunderstanding of capacity to think that having a mental illness means that the person lacks decision-making capacity. And then mature minors, pragmatically, I think that we could still have more stricter criteria while still allowing it. So I think MAiD should be allowed for mature minors, but I'm somewhat agnostic about what the specific criteria should be. Perhaps it should be more stringent for them just to make sure. So it's a 17-year-old, they have full capacity, they've been assessed, but maybe there are additional safeguards in place.
I like the expression I'm agnostic about this. And I'm agnostic about the next thing I want to extend our discussion on. So, thinking about advance requests and also thinking about how medical assistance in dying was established within the context of what I consider a medical model. So that the request is between the individual who would receive MAiD and their healthcare provider and doesn't necessarily involve the family. And as a social worker, I very much think that we do not die in a vacuum and that people who are involved in our day to day lives are very much impacted in our living until we die. And so when I think about things like advanced requests and recognize some of the challenges that might be, I'm wondering, how do you see the role of family? And by family, I'm talking chosen family, not necessarily biological. And thinking specifically like how in Ontario, we have substitute decision makers. So at a point when we're not able to make those choices or to verbalize them, that there's somebody who's on board. Do you think there's space for that within MAiD care?
I do think that there's space. I think that thinking about autonomy much more broadly, for a long time, we've had in place advanced care planning, and each province has its own approach to this. But being able to document our wishes so that we get the care that we want and we don't get treatment that we don't want when we're no longer able to make our own decisions. And family members or substitute decision makers can play a role in that. I'm really interested in Quebec's approach because it takes the substitute decision maker out of it, which has a number of benefits. That requiring consent from a substitute decision maker, in some cases that works out fine, but as a clinical ethicist, I've seen heaps of cases where that doesn't work out fine, where even if the patient's wishes are clearly documented, that the family member is unable to make that decision. They feel the responsibility of it, or they don't trust the advance directive, or there's disagreement between family members. 80% of the cases that I'm involved in as a clinical ethicist involve substitute decision-making issues one way or another. So I think it's a very interesting strategy that Quebec has taken, which removes all of those potential issues by making it a one-on-one agreement. And so I think it's an interesting approach. I'm also let's wait and see what the data says or how it rolls out. It just hasn't been going on long enough to be able to make any strong conclusions. But I do think that substitute decision-making is a good system. It's really the best we could come up with. So I can see a role for that. It doesn't have to be the Quebec approach, but we have to recognize that anything like bringing in substitute decision makers, family members, and so on, that comes with complications or potential downsides.
Yeah, and added layers of complexity, which I think when we don't include them, we also might see later on in terms of their own grief experiences or trust in the healthcare system as well. And yeah, I too am watching Quebec really closely as things change. I'm wondering, Eric, do you have any thoughts about why other provinces haven't adapted things the same way? Like, I'm thinking of a couple of pretty big changes, advance requests, and also saying, guess what? Buildings don't have the right to be conscientious objectors, particularly if they're publicly funded. Thoughts why the rest of the provinces are a little bit slow on the uptake?
It's illegal. Quebec is breaking federal law, and Quebec can get away with that in a way that I think the other provinces are probably not willing to try. So bless them for trying this out. And now it's forced the federal government's hand to try to consider it. The conscientious objection, I very much agree with the approach that Quebec has done. And there's lawsuits going on elsewhere in Canada to try to press that point to get courts to take that view. But I do think for Quebec to say, well, we're just going to ignore the criminal code on this point, which specifies that the person has to give consent at the time of the MAiD provision, even though that's the conclusion that I want, I think that as a process point, I don't encourage that. We should be thinking about following the process. And if we can get the federal law changed, then I think that'll be much better. Spain recently legalized assisted dying just a few years ago. And their approach was just to say, MAiD is a healthcare decision. substitute decision makers can make other end-of-life decisions. They can withdraw life-sustaining treatment. They can change to palliative care, et cetera. So we're not going to treat MAiD any different. And I think that's a ethically defensible view. So once again, wait and see what the data says. But there's no ethical difference to carve out MAiD in the way that the federal law does right now.
I really appreciate you encapsulating Spain's kind of status. And that is a beautiful segue into our next question for you, because in our episodes, we hear a lot about this idea of the slippery slope. And if we allow this, when the floodways are open, and can you talk to us a little bit about what you mean, not a slippery slope, if it's ethically defensible?
Sure. I should just say first, I didn't realize that this was one of my turns of phrase, and that apparently I say this a lot. So maybe I'll get shirts made or something. You can buy my, say, ethically defensible on it or something. Okay, slippery slopes. Slippery slopes are so fun. And one time I spent like a week going through the media archives to find instances where people have used slippery slopes, because they're everywhere. They're used by every political stripe to defend any kind of view. The standard, most up the middle argument structure for a slippery slope argument, the person says, okay, sure, there's this proposal, and if we accept this thing, maybe it'll be fine. However, it'll put us on this slippery slope, this path where necessarily it's going to lead us to this totally unacceptable result. And for example, when same-sex marriage was being discussed in Canada, there were articles all over the place saying, if we legalize same-sex marriage, what's next? People are going to be able to marry multiple people. People are going to be able to marry animals. It's just not going to stop. And so we shouldn't allow same-sex marriage. Same with drug legalization, that we legalize cannabis, then it's going to be whatever. Any kind of drug is going to be legalized. And of course, those things haven't happened. And it's not that a slippery slope argument is always fallacious, not a valid form of arguing, but we should be very cautious about them because it's making a prediction, and the future is hard to predict. And the more kind of dire and Black Mirror-ish dystopian that the prediction is, it resonates with people. People latch onto them. That's why slippery slope arguments are so sticky. But we should be very careful about accepting them because most of the time they're not true. So the way this comes up with MAiD is that people have been saying for a long time that if we allow MAiD, sure, maybe it'll be fine at first and it'll be really controlled, but then over time, the criteria are going to get chipped away at and it's going to get worse and worse. And then eventually it's going to be murder. It's going to be Nazi Germany. It's going to be whatever kind of horrible situation people can invent. And for the very same reason as in those other cases, there's just no reason to think that's going to be the case, that many places like Oregon has had assisted dying since the 90s, and they've had a couple small tweaks to their legislation, but essentially the legislation hasn't changed. Canada has expanded, but I think has expanded to go back to what was originally described in Carter. So I also don't think that it's like, to call it a slippery slope, to call it expansion in the first place, is a misdescription. Anytime you encounter a slippery slope argument, you should immediately just put a big question mark next to it.
Thank you for that. I appreciate, putting the big question mark by the slippery slope argument, I think is an important one. As we were talking about advance requests and what is going on in Quebec, I'm wondering, Eric, if you can talk a little bit about a waiver of final consent and talk about the difference, because I'm really appreciating how clear you unpack some of these really important ideas within the context of MAiD. We have heard from listeners that there is a bit of confusion between a waiver of final consent and advanced request.
Sure. So a waiver of final consent was added into the legislation, and it can be invoked if it's looking like the person who is qualified for MAiD is likely to lose capacity very soon. And in that case, they can set a date by which that if they've lost capacity at that point, the provider can still proceed with the MAiD provision. So it's much more restrictive. The timeline is much, much narrower. And I forget exactly the number offhand, but it's pretty small. It isn't used very much. The reason that was brought in, though, was that there were just these horrible stories that were coming out prior to it where a person would qualify and then would lose capacity. And sometimes in order to avoid losing capacity, they would not take pain medication. They would just be in total agony so that they could give consent to MAiD. And in other cases, tragically, the person would qualify for MAiD and then lose capacity and then continue to stay alive without capacity, unable to give consent to MAiD for a while. So advance requests, the way Quebec has implemented it, is that once you have been diagnosed with a medical condition that will qualify you for MAiD eventually, that will cause a grievous and irremediable medical condition, that will also cause you to lose capacity eventually, so something like dementia, that you can make an agreement with a specific healthcare provider, a MAiD provider, that you define what the criteria are. And then in the future, once you've lost capacity, if you meet those specific criteria and it's confirmed by another person, then they can go ahead with the MAiD provision.
And I think, as you've highlighted, that goes towards this idea of demedicalizing medical assistance in dying. And in our research, Keri-Lyn and I, in the early days of MAiD, heard stories of that you're describing, people not taking pain medication or wanting to have that last drink, a really important whiskey or gin to that individual, but not being able to do that because of that need to be able to give consent in the moment, or feeling like they weren't able to do that. And so I think those pieces are really important to be able to address. And I'm wondering, Eric, can you talk a little bit about, it feels these days that medical assistance in dying is still a pretty hot button topic and a little bit controversial, despite how, dare I say, pragmatic you speak to it from the perspective of an ethicist. And I'm wondering, have you encountered any challenges or backlash in the work that you are doing?
Yeah, I think first to say that it's actually not clear to me. It gets attention in the media and so on. It's actually not clear to me that it's that controversial in general. I think that the polling shows that 85% of Canadians still agree with assisted dying. Like, the numbers just have not budged despite the controversies that have occurred. It's gotten a lot of international attention, and I think that's unfortunate because I think that that coverage is typically against assisted dying, and I think is just bad journalism. So I think that's unfortunate for other jurisdictions. When I was in Ireland, we have a reputation now. The stories that people know about are ones that actually, when you look into them, either don't check out in terms of the facts or don't check out. And I think just like the ethics of them are different from how they're portrayed. In terms of pushback and stuff that I receive, sure, people disagree with me. And I think that's good. That's positive. A lot of the stuff that I've written about is looking at arguments that people give against MAiD and assessing them. Are they true? Both like factually, empirically, the numbers that they're using, but also ethically. Is there like, what's the best case for them? And some of this is just kind of foundational disagreements about values or about what the goals of medicine are or the role of physicians or how we think about people in society. But I think in another way, it's actually very disappointing. The last few years, especially, it seems that the kind of main, there's like a handful, 4 or 5 people, MAiD opponents who get a lot of press and who write about it a lot. And it seems like their strategy has basically just been to do their own thing and just, yeah, not respond at all to any arguments. There's just no engagement. And it's sad for me because I've written like in-depth, good faith arguments trying to assess those and point out mistakes. And sometimes there are ethical differences, but sometimes it is just like, I, as a philosopher, like with a pretty limited kind of knowledge of statistics, I think that the people who are employing statistics are just making some pretty like bad statistical mistakes. And they just keep saying it. And so I know that maybe they don't read my posts, but like, I know they've heard about them. When I was still on Twitter, I like sent them to them. So that's been frustrating, is like just the lack of conversations now, where it's just these silos and they keep saying the same talking points and do not want to have conversations about it. So maybe it reflects like broader kind of stuff going on in society and in media and so on. But I think actually that when I think about like pushback, the most disappointing thing for me is like the lack of pushback. I want to have actual conversations with these people, and just doesn't happen.
Yeah, I love that way to kind of spin that around on its side and say pushback, because I would like to hear. I have a bit of a random question for you, Eric, because I'm super curious, knowing you very much on the screen and in print, and now being able to speak with you. I'm not a philosopher, but I dwell in some deep thought processes, and I'm a real kind of, yeah, like I'm going to marinate that for a while. How do you, as a philosopher, reconcile the theoretical with the practical? So basically, what I'm asking you, Eric, is how do you sleep at night? How are things going for you? Kathy and I often ask our guests who are healthcare professionals, how do you take care of you and your teams in these spaces? I guess I'm asking you as a philosopher, how do you take care of yourself when you have to have these coexisting thoughts and these myriad contemplations? How are you doing, you, Eric?
Thank you. I think my critics will be surprised that I say this, but I really do enjoy changing my mind. And I am really, and teaching my students this as well, that like you should hold things only as tightly as they deserve. And if you come across like arguments against it or evidence to the contrary of your view, get rid of it. Like, who cares? Like, it's just a view. And it's very much easier said than done. But philosophers, we just argue with each other. And like, you're only like a real friend to a philosopher if you like really try to tear that person's arguments apart. And that's like what it means to be nice. But MAiD, I sleep like a baby. As I said, like even from the beginning, I just think that the objections are not very good and people can have disagreements in many different ways, but the standard is too high. They think, oh, so if there's one like controversial case every once in a while, like that means we should ban all MAiD. I just think that's like a totally unreasonable bar. If they had like any experience in healthcare, they would see that like there are problems all over the place, and making a big deal out of MAiD and thinking that MAiD is the problem, or that banning MAiD is going to help people who are living in poverty or people who are living with disabilities or people who don't have good access to housing. It's just nonsense. And I think either they just haven't thought it through, which is like not very polite, but they haven't actually thought through the consequences, or they have some focus on MAiD because maybe that they think that's like an easier victory to win than like caring about affordable housing or trying to do something on that. But I think MAiD is not the issue. So there are other things, problems that do keep me up at night or that I dwell on a lot and that I try to figure out. But I just don't think MAiD is one of them. I think it's being like intellectually honest with oneself about taking a really good look at the thing. Like, how confident am I in holding this view, and stress testing it, trying to figure out does this really hold up to scrutiny? How might somebody object to it? What are the objections out there? I read a lot of the objections because I'm looking for a good one. That would make me happy and it would give me something to write about. Like, I guess bring it. MAiD is not it's controversial in the public, but I think that like ethically, it's just not where the controversy is.
That is great. It sounds like you sleep well at night. And I really would like to take your death and dying course, Eric. I think that I would love to sit in on that. So I'm interested if you're going to look into your very informed and well-educated Magic 8 Ball. What do you think is next for MAiD in Canada? What do you think should or needs to happen?
Yeah, so that I'll give you my list of what I want to happen, which is different maybe from the predictions. I think allowing MAiD for mental illness, that is certainly one on the horizon. There's a lawsuit going on for that, which I'm optimistic about. I think stopping forced transfers, or stopping institutional conscientious objection. There's also a lawsuit in the works on that I'm optimistic about. I think that advance requests. So in the early days, 2016, when MAiD first became available, I was working in a hospital in Toronto and talking to people and saying, oh, this is legal now. And the thing that I heard most consistently was like, oh, great, because the thing I'm most worried about is getting dementia. And then I would want to end my life in that case. I would have to say every single time, the legislation's not going to allow that. And so this is something that Canadians really want. It's like a thing that they worry about a lot. And so with Quebec leading the way, I think that it's something that absolutely ought to be done. After that, the kind of the rare cases, mature minors, I always forget how to say it, but the Groningen protocol. So for newborns, like there are tragic cases that do come up and assisted dying can be applied in other ways, but those are totally different paradigms. It would really change what the approach should be. And so I'm paying attention and thinking about those things. But yeah, I think mental illness, forced transfers, and advance requests, those are the key things now.
I'm going to push back a little bit, Eric, because I appreciated that you differentiated between what you think should happen and what you think will happen. So what do you think will happen moving forward? We have a new government in place.
From a MAiD perspective, I'm comforted about the Liberal government instead of the Conservatives getting in. I actually haven't really seen if Carney has mentioned it, and I think that's probably a good move on his part. I think that the lawsuits going on, that the teams involved in those are extremely strong, extremely capable, and they only go after stuff that has a good chance of succeeding. If I will I don't know if it's legal to like place bets on those, but I would place a bet with somebody on those if somebody wants to take the other side of that. Advance request, I think the federal government is just, for it to continue with only allowing Quebec for very long is not going to be sustainable. So I think that the federal government will do something with that eventually, but exactly what that looks like, I don't have a good prediction.
Thank you. And I appreciate, who knows what that timeline will be. I think eventually things will have to change, but yeah, who knows with that. So thank you for that. Eric, just in conclusion, was there something else that we should have asked you about today that we missed on?
Nothing you missed, but I do think it's worthwhile to zoom out and think about that. I think that MAiD is one chapter in a much larger story of changes in healthcare through the 20th century and into the 21st century that is really about patient rights, letting people make decisions, being in control of their own lives. And I think that MAiD is just one part. There are many other things. So thinking about advanced care planning, one thing I worry about is that people will think that I think that MAiD is like a good choice in every case, or that it's like a thing that you should do. And that's not my view at all. I support MAiD because I support people being able to make choices for themselves. And if there are people who don't want MAiD, and certainly I've met those people, that's totally fine. What I care about is people getting care, or their lives and at the end of their lives aligning with their visions of what they want that to be. So I think that MAiD is an important part of that, but we should also think about all the other ways we think about death, our relationship with death, and spending time to think about that those are important things too.
And it is solely, as you have said, one piece of that conversation when we think about people's options and opportunities at the end of life, and having that education, knowing what they can expect or can ask from the health and social care system, and also from their communities in which they are living, hopefully well until they die. Thank you so very much, Eric, for your time today. And I've thoroughly enjoyed our conversation, and meant that sincerely, that I would love to be sitting on one of
Same.
your courses.
Same. I would be right up front there, Eric.
Thank you both so much. That was a fun conversation.
As predicted, Kathy, that was an incredibly rich discussion. I thoroughly enjoyed meeting Eric Mathison. I really had a chance to delve into the work that he does, and I was super excited, and it paid dividends. I loved that discussion.
I really did too, and it's given me a lot to percolate about, particularly his comments around the slippery slope. And when we're using that as an argument, that calls for action on our part to delve a little bit deeper and see where that argument is actually coming from.
I appreciate that as well. I also love the fact that he's sleeping like a baby. I really appreciate that. And I like the idea that we got to ask him that question. We ask our healthcare professionals and our caregivers how they are managing. We need to ask philosophers out there who are delivering courses around death and dying how they're doing and what they think about things.
I agree. And I also appreciated that he said he welcomes pushback. He welcomes debate and the opportunity to think about, or continue to think about, issues from both sides of the conversation. Dear listeners, that's us too. So if you want to argue with us, of course, in a respectful way, we would love to hear from you in terms of what we're missing in the conversations that we're having on disrupting death, and what we should be engaging in next. Because Dr. Mathison said those conversations are important, and that's what we need to be doing, deepening our understanding not only of MAiD, but living well until we die. So until next time, thank you so much for listening to Disrupting Death.